Hi, I'm Betsy Nicoletti. Thanks for joining me today. I hate to even say this is the 2024 edition of the Split and Shared Evaluation and Management Services. What I'd like to say is I hope it's the final edition. But since I think I've done them in 2022, 2023, maybe I'll be doing them once a year for the rest of my life. I don't know. So we're going to start with some definitions. We're going to talk about CPT because CPT changed. They added to greatly, they increased their definition of split and shared services in the CPT book, which weren't in the CPT book before 2021. It was only a Medicare concept. And what Medicare said in their final rule that they released November 2nd, 2023. So CPT says physicians and other qualified healthcare professionals, and these are people who have E&M in their scope of services, NPs, PAs, clinical nurse specialists, certified nurse midwives, may act as a team in providing care for the patient, working together during a single E&M service. Medicare describes these split shared services as services furnished in a facility setting. A split or shared service refers to an E&M visit performed by both a physician and a non-physician practitioner, someone who can do E&M, in the same group practice. So same group, same specialty can share E&M services. Each of the practitioners can provide part of the visit. In the non-facility setting, Medicare says, for example, in the office, the rules for incident to billing circumstances applied, so not split shared. So CMS says we're going to adopt some of the CPT definitions. We want to reduce administrative burden, and we're going to continue, even though we said we weren't, we're going to continue for 2024 to allow either time or MDM to determine the substantive portion. And happily, they've taken out that perform in its entirety one of the key components because the key components aren't relevant here. CPT doesn't mention location. They aren't relevant because CPT took those out of the CPT book in 2023. CPT doesn't mention location, whether it has to be could be a facility or non-facility setting. So for commercial payers, we're going to have to look at their individual requirements. For CMS, it's facility settings only. So Medicare reminds us that if you are in place of service office, you can't bill split shared. You can only, you've got to go instead and look at the incident to guidelines. Now let's just review briefly the three elements of medical decision-making. And there's a reason for it, unfortunately. The number and complexity of problems addressed, the amount and or complexity of data to be revised, and the risk of morbidity and or mortality from patient management. And of course, we know we need 2 out of those 3 to determine our level of service. And CPT is going to talk about determining the substantive portion of the visit for 2 categories of data differently. Okay, so if we are using the complexity of problems and the risk, then we're going to have, because that would be 2 of our 3 elements. This is what CPT says. Performance of the substantive portion of the MDM requires that the clinician made or approved the management plan for the number and complexity of problems in the plan. By doing so, the physician or other qualified healthcare professional has performed 2 of the 3 elements used in the code selection. So let's pretend there's no data in the visit. This visit, we're going to select our level of service based on the number and complexity of problems and the risk of patient management. CPT says that the substantive portion is done, it can be attributed to the person who made or approved. So CPT doesn't say anything about documentation, but made or approved. Does this imply an attestation statement is allowed from CPT? Now, Medicare says Although we continue to believe that there can be instances where MDM is not easily attributed to a single physician or NPP when the work is shared, we expect that whoever performs the MDM and subsequently bills the visit would appropriately document the MDM in the medical record. So the billing practitioner would appropriately document. Now, they don't define it. They don't say we do or don't allow attestation statements, but CMS has been consistent in the last 3 or 4 years in the way they talk about split shared. And we know what the big deal is. If the physician reports the service, we're paid at 100% of the physician fee schedule amount. And if the non-physician practitioner performs the service, we're paid at 85% of the fee amount. And CMS has continued to say that that is what they want to do. And that if they're going to pay for the higher amount, the 100% of the physician service, they want the physician to be performing the service. So that, in my mind, does not make an attestation statement. That means if the physician is going to bill for it, they're going to do it and appropriately document it. But data is a little bit more complex. So CPT says, and these are all from page 6 of the CPT book, all these quotes. If the amount and/or complexity of data to be reviewed and analyzed is used to determine the code level. So now that's going to be one of our elements to determine the code level. The person who's billing it does not have to personally have assessed the independent historian, doesn't have to be the person who orders or reviews the tests or documents. If that's part of the work, those do not have to be personally performed by the person who is billing for the service, because those would be considered as part of formulating the management plan. But if we're going to use independent interpretation of tests or discussion of management plan or test interpretation with another healthcare professional, if those are used in determining the level of service, then, and the substantive portion, they must be personally performed by the physician or other qualified healthcare professional if they're used to determine the reported code level. So when we think about this, we're going to decide on our level of service, but what we're talking about here is determining the substantive portion. So if using the problems, most data, the number and complexity of problems, most data elements, and risk to determine MDM and select the level of service, those do not have to be personally performed by the person who's billing for the service. But if you're using independent interpretation of tests or discussion of test results or patient management to determine MDM, so that's category 2 and 3, if we're looking at moderate or high data, high or, it's not high, extensive data. Those must be personally performed by the physician if these are used to determine the reported code level. So CPT is making a distinction between performing an independent interpretation of a test, looking at the image or tracing, or discussion of test results or patient management with another healthcare professional. If those two are used to determine the level of service, those must be personally performed by the physician in order to determine the level of code. So substantive portion based on medical decision-making. Obviously, time is much easier. It's whoever performed more than 50%. But based on medical decision-making, the medical decision-making can be determined by the person who made or approved the management plan for the number and complexity of problems addressed at the encounter and takes responsibility for that plan with that data caveat that we just went through. So made and approved. But CMS says whoever performs the medical decision-making and subsequently bills the visit would appropriately document the MDM in the medical record. So those two are not the same. And CMS has been clear that if they're going to pay at 100% of the fee schedule, they expect the physician to be doing the work. So this is our MAC here in New England, New York, a couple of other places, and this is pre-2024. And they said, in order to bill the substantive as the substantive provider, the physician's documentation would need to describe the work as exceeding the NPP's work in completing the service. So obviously, we expect NGS is going to update this, but even before the CPT changes, the expectation is that if the physician is billing for it, their work exceeds the work of the NPP. So we've got our work cut out for us. Will CPT clarify some of these rules in the upcoming CPT assistant issues? They probably will, but they typically don't talk about documentation anymore. We're going to have to see what private payers allow and require. We've had to do that for Incident 2 forever and ever. Some of the things that we must do is check your MAC. For Medicare, I really recommend not using this attestation statement unless your MAC specifically allows it, which I'm doubtful is going to happen. And then when will we hear more from Medicare? So CMS, they had the proposed rule, now I've got the final rule, and now they send out some transmittals and update their manual system. But there are a lot of changes and CMS can't do them all at once. So typically these transmittals and changes to the manual system come out in the spring. So we may have a while to wait until we see if there's any additional information from CMS coming. Here are the 2 citations, and then just non-physician practitioner, that's what Medicare says. Qualified healthcare professional, that's what CPT says. I wish they'd agree on an abbreviation. Of course, I wish I never had to talk about split shared in 2025. I wish this is the end, but we'll see. So I'm Betsy Nicoletti. Thanks for joining me today. There are other quick videos, both on YouTube and on Coding Intel, and of course, more detailed information on the website, codingintel.com.